Okay, so good morning everyone. Today we are going to continue with the anatomy book club. Dr. Helmut will talk to us about the radiological anatomy of the spleen. You can start.
Good morning, everybody. Today we will discuss about radiological anatomy of the spleen. The spleen is in the left upper quadrant of the abdomen. A portion of the spleen may be adherent to the anterior surface of the left kidney, giving rise to a bare area of the spleen, which is analogous to the bare area of the liver. The spleen is in the size of a fist, measuring up to 12 centimeters long, 7 cm wide, and 3 to 4 cm thick. Its long axis is in the line of the 10th rib, and its lower pole does not usually extend beyond the mid-axillary line. The spleen has a smooth diaphragmatic surface related through the diaphragm to the costodiaphragmatic recesses of the pleura and the 9th, 10th, and 11th ribs. The visceral surface of the spleen faces anterior-inferiorly, and to the right, its contours correspond to its relationship to the stomach anteriorly, the splenic flexure of the colon inferiorly, and the left kidney posteriorly. The splenic artery enters and the splenic vein leaves the spleen as 4 or 5 branches each at hilum. Between the gastric and renal impression, the tail of the pancreas also lies the splenic hilum. Blood supply of the spleen is through splenic artery, which arises from the celiac trunk. The venous ranges from inferior mesenteric vein and joins with the superior mesenteric vein to form the portal vein. We will discuss this later. Anatomical variants of the spleen are not rare. The spleen develops in many parts in the dorsal mesentery of the stomach at 5 to 7 weeks of intrauterine life. These parts are represented in an adult by the segments supplied by each branch of the artery. The adult may, however, have multiple spleens or may retain some fetal lobulations. Up to 10% of the normal adults have fetal lobulation. In addition to a normal spleen, accessory spleens called spleniulus or spleniculi. These occurs most commonly in the splenic hilum or near the pancreatic tail, but may also be found in the small intestinal mesentery or in the great omentum. Anatomical asplenia means no spleen, and polysplenia means several small rudimentary splenic bodies are associated with congenital heart disease, and isomerism means bilateral right or left-sided anatomy of the heart, bronchi, and abdominal structures. This reflects the development of the spleen and the heart at the same period of intrauterine life. Functional asplenia occurs where because of an interruption to the blood supply or diffuse disease. No spleen is seen in imaging, such as scintigraphy, which depends on functioning splenic tissue, a wandering or called wandering spleen. Wandering spleen is a rare condition characterized by abnormally lax, deficient, or long splenic attachment ligaments, which allows the spleen to move in the abdomen and possibly tort on its pedicle.
So the spleen can be seen practically anywhere in the abdomen because it might be a wandering spleen. And ligaments are lax, so it moves around. First, sometimes some diseases cause the spleen to die, resulting in asplenia, but it is a functional asplenia. Functional splenectomy. There is no surgery. Okay, just the spleen is not working, it's dead for any reason. Okay, and you can have spleniules or spleniculi, small mass-like spleens, small spleens in the abdomen around the spleen. They are very common, extremely common. You see them. They look like the spleen on every imaging modality, with contrast, without CT, MRIs. They look just like the spleen, but small and rounded. Okay.
They have a vein and artery.
Also. Yeah, just like a spleen. Okay, but small. What else we have? Congenital asplenia can occur with left or right isomerism. Means the body is both sides are left or both sides are right. Can have asplenia or polysplenia. Both of them can have.
So, radiological features of the spleen. First, we will start with plain films of the abdomen. The spleen is often not visible, but its lower pole may be outlined by fat. Its size and position may be deducted from the distance between air in the lung and its impression on the gastric or colonic gas shadows. Assessing its size by measurement of its width 2 cm above the splenic tip on plain films is less accurate than measurement of its length from the dome of the diaphragm to the tip. This is usually less than 40 cm. The relationship of the spleen to the 9th, 10th, and 11th ribs is important in plain films of trauma cases where fractures of these ribs is associated with splenic rupture. This is a plain X-ray demonstrating spleen and stomach shadow, as you see.
You can see the spleen here.
Yes.
Okay. Between the left hemidiaphragm or the left lung and the adjacent colonic and gastric gases, you can have a rough idea about the size of the spleen, which should not be more than 14 centimeter in any dimension. Okay.
Okay. Ultrasound of the spleen. The spleen is of similar echogenicity of the liver or even higher, although the liver may appear more echogenic because of the reflectivity of its many vessels. It usually measures less than 12 cm in its long axis. The splenic vessels are best seen when enlarged. The spleen enlarges anterior to the colon and becomes easier to see on ultrasound. Retroperitoneal masses by comparison may be masked by colonic gas. Splenomegaly can be identified by ultrasound by demonstrating supply by the splenic artery and drainage by the splenic vein. This is a normal ultrasound showing normal spleen, homogeneous, moderately echogenic, less visible vessels than the liver, as we say. Second set of veins equivalent to portal vein. Computed tomography of the spleen. On CT, the spleen is seen as a homogeneously enhancing in the arterial phase, as palisading pattern of enhancement of the splenic sinusoids, roughly parallel bands of the enhancement separated by non-enhancing connective tissue may be seen. Its relationship to the diaphragm, pleura, ribs, and to the pancreas, stomach, colon, and left kidney can be appreciated by CT scan. The spleen is enlarged if anterior to the aorta or extending below the ribs. This can be seen by CT scan.
The CT, we will have two different appearances of the spleen, in the arterial phase and in the venous phase. In the arterial phase, the spleen will show homogeneous or heterogeneous enhancement.
Homogeneous.
Heterogeneous.
In the arterial?
In the arterial.
Yes,
then it will become palisading. Okay? And then it will become homogeneous in the venous phase. So when you see this pattern, go back to the CT. When you see this homogeneous spleen, this is venous. Okay? While if you see it branching like palisading pattern,
Palisading, yes.
arterial. Okay?
Palisading means
like
parallel
arches.
bands of
Something like
enhancement
arches.
separated by non-enhancing connective tissue.
بالضبط.
This is a CT scan demonstrating spleen, pancreas, abdominal, aorta, liver, and gallbladder. This is a coronal image also of CT scan.
Good. Number one is the spleen, of course.
Number one is spleen, yes.
And this is a venous phase.
Yes, because it's homogeneous.
Well,
MRI of the spleen. The spleen is readily visible on MRI, and its relationship to the diaphragm, left kidney, and adrenal gland can be appreciated, especially when on sagittal and coronal imaging. Poor differentiation between the normal spleen and tumor may be improved by the use of reticuloendothelial contrast agents. This is also CT scan or MRI, yes.
this is a CT scan without contrast. Okay?
Yes.
And this is an MRI, in phase and out of phase images.
In phase and out phase of the.
These images are particularly were done for the adrenals, for adrenal adenomas. But however,
just to see
we
spleen,
can
yes.
see the spleen here. You can see in phase it's darker than out of phase images. We will talk about in phase and out of phase later. Okay.
This is T2 image of the spleen.
And this is the T2 image. You can see the spleen and the liver are almost the same signal intensity, more or less, but they're almost. of the same signal intensity. Okay.
Nuclear imaging of the spleen. Technetium labeled sulfur colloid is taken by the Kupffer cells of the reticuloendothelial system. Activity may be seen in splenoles in addition to the normal spleen and the liver.
So the reticuloendothelial system has something called Kupffer cells. Wherever they are, they will take the sulfur colloid. Okay. So wherever there is reticuloendothelial system will be seen by Scintigraphy. For example, if you have someone with, let's say, thalassemia, and he did a splenectomy, and he's not improving, he's still having anemia, there might be another spleen or splenicule somewhere. How to be sure? You give him sulfur colloid and you see, is there a spleen
Activity.
somewhere else or not? Okay?
high sulfur colloid special for spleen high
For reticuloendothelial system. موجود بالليفر، موجود بالسبلين، موجود بالبون مارو. You will see the liver, you will see the bone marrow, anything
You will
else
see
is
according to
spleen.
the location.
Okay? You will not see a liver somewhere else. The liver is in its place. The spleen might be somewhere else. Okay, so.
We will continue with the portal system anatomy. What's the portal venous system? Blood from the gastrointestinal tract, not including the anus, the spleen, pancreas, gallbladder, drains to the liver via the portal venous system. This consists of superior and inferior mesenteric and the splenic veins, which unite to form the portal vein. There are valves in this system in the fetus and young infants, but not in the adult. First, superior mesenteric vein. This lies to the right of the superior mesenteric artery and drains the area supplied by this artery. Its branches are similar to the arterial branches except proximally and are as follows. Right gastroepiploic and inferior pancreaticoduodenal proximally, jejunal and ileal branches to its left side, ileocolic, right colic and mid-colic branch to its right side. Inferior mesenteric vein. This lies to the left of the inferior mesenteric artery and drains its area of supply in the colon via left colic, sigmoid and superior rectal veins and some pancreatic branches. So the inferior mesenteric vein lies to the left of the inferior mesenteric artery, but in superior mesenteric vein lies to the right of the superior mesenteric artery. The splenic vein.
Because the inferior mesenteric vein the artery goes to the left, so the vein will be on the left, while the SMA goes to the right more, so the vein will be on the right.
Yes. The splenic vein, four or five branches leave the splenic hilum and unite to form the splenic vein. Occasionally, a vein from the upper pole of the spleen joins the splenic vein more proximally. This is called the superior polar vein. Proximally, the splenic vein receives the short gastric veins and the left gastroepiploic vein from the stomach. It receives multiple pancreatic branches and the inferior mesenteric vein as it passes posterior to the tail and body of the pancreas. Then the splenic vein unites with the superior mesenteric vein to form the portal vein behind the neck of the pancreas. Portal vein. The portal vein is formed by the union of the superior mesenteric and splenic veins. Superior mesenteric and splenic veins behind the neck of the pancreas. At the level of L1, L2 vertebra, it then runs to the right behind the neck of the pancreas and receives the superior pancreaticoduodenal vein. It passes behind the first part of the duodenum and receives the right gastric and left gastric, coronary veins. It's separated from the IVC by the epiploic foramina. Its proximity to the IVC at this point is utilized at surgery for portosystemic venous shunting in portal hypertension. At the porta hepatis, the portal vein divides into right and left branches. The right branch receives the cystic vein if one is formed, and the left receives the paraumbilical veins. The portal vein is distributed with the branch of the hepatic artery. something called portosystemic anastomosis. Portal venous pressure is raised when there is obstruction to the blood flow in the portal vein, the liver, or in the hepatic veins. Portosystemic collateral pathways then open where these two systems communicate.
So, the portal vein is a system that takes the blood from the GIT everywhere in the body. Venous blood will go directly to the heart, except from the GIT. Venous flow blood will go from the GI to the liver to the heart. There is checkpoint, the liver. Okay? سيطرة أكو بالنص اللي هي liver. Because the chemical substances from the GIT will go to the liver for storage, detoxification, metabolism, I don't know what. Then they will go to the heart. Okay? So the blood will come from the spleen and from the GIT by the superior and inferior mesenteric veins. They will join together, form what's called portal vein. Portal vein will take the blood to the liver. Okay? So if there is any problem in the liver, okay, the venous blood flow in the portal vein will be difficult. There will be increased pressure.
Yes.
Okay? Blood will not flow in the portal vein. So where does the blood go from GIT? It will start opens other pathways, collaterals. يفوت بالفروع خلينا نقول إذا السيطرة مسدودة. Okay? So it will form collaterals, will shift the blood bypassing the liver, goes into the venous system directly. Many collaterals, and this is a big problem. The collaterals will be they will solve the immediate problem here. The liver is hard, but will create other problems. That the blood is shifting from the liver, going directly to the systemic circulation. So what are these collaterals?
Portosystemic are collaterals according to site and portal system and systemic, and the vein from the portal system and the vein from the systemic veins.
Okay.
According to site, we have gastroesophageal junction. The vein from the portal system is left gastric vein, and from the systemic is esophageal veins. From the rectum, we have superior rectal veins and inferior rectal veins. From the retroperitoneum, lumbar and phrenic area, tributaries in the mesentery, retroperitoneal and renal veins. From the umbilicus, para-umbilical veins with the ligamentum teres, and from the systemic veins of the abdominal wall. So we have four major sites, collaterals. These are sites of varices. As you see here, a diagram demonstrating esophageal varices. Here gastric varices, parastomal varices, rectal varices, and paraduodenal varices.
So all these are veins that will enlarge, become big, because they are shifting the blood from portal circulation to systemic circulation. When they become big, and they should not be that big, they will cause problems. They will cause bleeding. They will cause a lot of different issues. And they are difficult to treat because the liver is bad. So they do what's called portosystemic shunt, and we'll talk about it later.
Yes. So the radiological features of the portal venous system, starting from plain films, the normal portal veins are not visible by plain X-rays. Ultrasound, the portal vein is visible on ultrasound as it passes toward the liver posterior to the common bile duct and hepatic artery. So the portal vein is posterior to the common bile duct and hepatic artery by ultrasound. Its diameter is variable but always greater than that of the normal bile duct. Portal vein branches in the liver are seen as having more echogenic walls than the branch of the bile duct. We can differentiate this portal vein by echogenicity of their walls. The splenic vein is an important landmark in ultrasound, as the direction and velocity of the blood flow, which is important to evaluate in portal hypertension. Color flow Doppler helps in identification of the vessels. This is an ultrasound image demonstrating portal vein, left portal and right portal veins, ligamentum venosum, caudate lobe, and posterior IVC. Normal portal venous circulation. This is another diagram showing splenic vein, coronary veins, inferior mesenteric vein, and uniting with the superior mesenteric vein and making portal vein, then to the liver in the porta hepatis to the right and left branch. This is an ultrasound image of the previous diagram. Superior mesenteric vein, inferior mesenteric vein, and splenic vein, they are uniting and
So the inferior mesenteric vein sometimes joins the splenic vein,
before.
sometimes joins the superior mesenteric vein, sometimes joins with both of them on a common hilum. Three
Yes.
of them joins together.
We have
So this is
common
obviously
veins.
superior, inferior, and splenic veins. All of them are joining together behind the neck of the pancreas to form the portal vein. This is a very nice. What's this? What's the image? Can anybody tell me?
CT or MR?
CT or MRI؟ صوت بدي اسمع شنو؟ MRI. What else؟ من يقول CT؟ من يقول MRI بعد؟ CT؟ ما ادري قولوا لي CT ولا MRI؟
ليش CT؟
ERCP بعد ما يسمى
ERCP.
شنو؟
شنو؟
MRI. Come on girls. This is a CT scan. Okay?
3D reconstruction.
3D reconstruction with or without contrast. الحمد لله with contrast متفقين. Arterial or venous phase.
Venous. لا هو
شو
we
يعني
are talking
بالسبب؟
about portal vein.
احنا we're talking about portal vein.
And they are
قدام شي portal
demonstrated.
vein. فايش
يعني
طالع؟
vein.
وإذا تبين more specific portal venous phase. Even more specific يعني. Okay? And this is what's called. ليش طالع الصورة هيك؟ يعني it's not like the image that we are used to.
Reconstructed.
Because this is an MIP, maximum intensity projection. The computer will show us only the things that have maximum intensity, the things that have maximum contrast, the IV contrast, حتى we can see the portal vein more easily, more obviously. Okay?
As you see, splenic vein, superior mesenteric vein, they unite and making portal vein. Then from to the liver and making left and right branches.
Good. Sometimes you can see it, sometimes you can't see it. انتوا ليش ما كنتوا متفقين؟ ما قارين. ايش ما ادري متفقين.
لا انبعي ليش دكتور بس انبعي اذا
This is يعني you have to know the يعني ارجع لي بالله ارجع لي. First of all, this is an IV contrast. Okay, that you can see it easily with CT, not an MRI. First, second, the density pattern is that of a CT scan. Third, you can see the ribs, the bones that are not cannot be seen on MRI like that. This dense. Okay, so obviously it's a CT scan. No need for. And the fat is dark. You can see around the liver. Usually it's dark. It's bright on T1 and T2 images. تمام.
CT scan of the portal veins can be seen in the porta hepatis and its branches are seen in the liver, generally posterior to the bile duct and hepatic artery, as we said by ultrasound. The portal veins is seen posteriorly in the free edge of the laser omentum. Here it is separated from the IVC by the epiploic foramina. The splenic vein is seen posterior to the pancreas and unites with the inferior mesenteric vein laterally and the superior mesenteric vein behind the neck of the pancreas. It lies anterior to the left kidney and its hilum, the renal vein and IVC. The superior mesenteric vein is seen to the right of the artery on lower slices, and together these pass anterior to the unisate process of the pancreas. Magnetic resonance of the portal vein. MR angiography of the portal system is an excellent method of providing detailed information regarding portal vein anatomy and portosystemic collateral vessels information. Regarding the portal blood flow, direction and velocity can be obtained using the time of flight or phase contrast angiographic techniques without the need for intravenous contrast. This is important clinically. With these techniques, the background signal is suppressed and flowing blood is bright. The source data can be viewed as an MR angiograms.
So MRI or MRV, let's say MR venogram, MR of the venogram of the portal system, MR angiogram of the portal system, with or without contrast? Without.
Wow.
هاي first لأنه MRI يعني يعطيك صورة بدون كونتراست. لا الا اعطيك كونتراست يعني شو زي هو تطلع بدون كونتراست يطلع جدا.
لا ما انه هاي يعني
زين. What is the sequences that we use?
Time of flight.
Time of flight اسمه. Okay. يعني يرمز له, it's coded as TOF, TOF, time of flight. So when you see TOF, this is not tetralogy of followed, this is time of flight. Okay. It is without contrast. It can show you the direction and even the velocity of the flowing blood in the portal venous system by MRI. Okay. Also, you can see the direction and the velocity using what? Using Doppler ultrasound. You can see the direction and the velocity. Okay. Is it important to know the direction and the velocity of the blood flow of the portal vein?
Of course.
Why? First, there will be decreased slowing flow, then very slow flow, then start reverse, flowing in the opposite direction. Okay? In the portal case of portal hypertension. So, the direction, hepatopedal, hepatopedal toward the liver, hepatofugal away from the liver. Okay? Direction. And velocity, what's the normal value for the portal venous flow velocity? No?
74.
Depends. Postprandial or fasting. إذا المريض ما ماكل fasting, okay, there will be nothing in the GIT to go to the liver. So the blood will be slower. If he's not eating, there will be food in the GIT to go to the liver. So the blood will be faster. Okay? So if he is fasting, it should be at least more than 11-12 centimeter per second. If he is postprandial, he's eating, the velocity of the blood flow should be around 16, 17, 18 centimeter per second. Okay?
Not more than 20.
Yeah. More is not no problem. If it's go toward the liver faster, مو مشكلة. بس إذا هو eating with velocity 12, this might be due to portal hypertension, slowing blood flow. Oh, he's fasting with velocity of the blood flow is like 5 centimeter per second. This is slow flow.
Yeah.
It indicates portal hypertension.
Portal hypertension first in the first
Decreased speed velocity, then reversed.
You mean by time or
With
the
time.
same time?
لا لا with time.
With time.
يعني بالmild will be decreased.
Decreased.
بالmoderate then lower decrease. Then the severe portal hypertension will be opposite.
Only in the severe will be
Moderate to severe, yes. Will be in the
so
opposite direction. Will go to the spleen instead of from the spleen. يرجع blood للspleen مكان ما يجي. Okay. High first. What else? How do we know the direction of blood flow by ultrasound?
by color.
By color. What color should be? Normally, what is the color of the portal vein?
It's according to the direction of the probe.
Good. According to the direction of the probe.
If it's
So-
toward the probe, it's blue. If away from
No, toward the probe should be red.
red. If
In a
against-
standard map, in a standard, towards the probe will be red, away will be blue. So, if the portal vein should be towards or away the probe from the probe in general, usually towards the probe, okay,
Towards.
because it's bringing. So it should be in a red color if your probe is in a good direction, a proper direction, okay. However, sometimes you just don't know whether the blood is going towards or away from the probe. What do you do to figure out the direction of the blood flow? You compare with the hepatic artery. They are always adjacent to each other. Portal vein, hepatic artery adjacent to each other. They should be always the same color. Both the red, both the blue, no problem. The hepatic artery is always toward the liver, always. Portal hypertension, no portal hypertension, tumor, I don't know what. Hepatic artery is towards the liver. So, portal vein, hepatic artery should always be in the same direction, same color. If you see one red, one blue, there is reversal of blood flow. Red and blue, غلط. Always the same color. Okay? زين. You have anything else?
Yes.
The diameter of
Thank you very much.
Portal vein diameter usually should be less than around 16 or 17 millimeter diameter. If it is more, usually indicates portal height. طبعا always you correlate this velocity with the diameter. يعني مثلا تلاقي velocity 5 centimeter مثلا per second والdiameter 12. ماكو شيء غلط بالموضوع. Usually when there is portal hypertension there is increased velocity, the diameter and decreased velocity.
Physical principle.
Yep, exactly.
Thank you very much. Today we finished with the lecture.
Good.
Next week we will continue with another parts.
Excellent. Nice. Thank you very much. Focused, short and practical.